Welcome. In this session, we'll be discussing about the anti-VEGF trials in neovascular AMD, which we have discussed in the previous session. We'll have a separate set of anti-VEGF trials to discuss for diabetic macular edema. There are a large number of anti-VEGF trials for neovascular AMD, and we'll try to describe them in a chronological order of their publication. First, we have the pivotal trials which compared anti-VEGFs, Ranibizumab and Bevacizumab versus non-anti-VEGF therapy such as sham and PDT. Then we have trials such as EXCITE and HARRIER which compared various doses and regimens of Ranibizumab, and non-controlled studies such as PrONTO and SUSTAIN which evaluated PRN dosing of Ranibizumab. Then we have an important group of trials which compared Bevacizumab versus Ranibizumab such as CATT, EVAN and other trials. And then we have trials comparing Aflibercept versus Ranibizumab such as VIEW-1 and VIEW-2, and the PULSAR trial which evaluated a higher dose of Aflibercept. The HAWK and HARRIER trials compared Brolucizumab versus Aflibercept, and the TENAYA and LUCERNE trials compared Faricimab versus Aflibercept. Then we have trials which evaluated treat and extend regimen meant to reduce the number of injections and the number of clinic visits. Trials evaluating real-world efficacy of anti-VEGFs in patients outside randomized control trials, which are mostly retrospective in nature unlike the other trials which are prospective. Trials evaluating combination therapy of anti-VEGFs with PDT and other agents. Then there are trials evaluating FDA non-approved agents such as drugs which are not yet FDA approved but available elsewhere, and drugs which are still in development pipeline. And finally, we'll very briefly discuss what biosimilars are. We must note that the three pairs of study VIEW-1 and VIEW-2, HAWK and HARRIER, and TENAYA and LUCERNE were paired parallel studies conducted simultaneously and having the same design. Most of the studies we are going to discuss are prospective multi-center randomized control trials, and we'll be mentioning the year of print publication of these studies as we discuss them. We'll also mention the phase 3 randomized control trials, which are very important in the sense that they are conducted immediately prior to approval of the agent. The parameters mentioned in most trials are as follows. Patient selected had treatment-naive subfoveal macular neovascularization with a minimum age at baseline and a minimum visual acuity at baseline. Treatment-naive means that the patient had not been treated previously for the MNV, and a minimum age at baseline ensures that the MNV is likely to be age-related and not caused by any other condition. And in trials evaluating PRN and treat and extend regimens, specified guidelines are mentioned when to retreat the patients in the PRN and treat and extend cohorts. Outcomes are usually measured with the following parameters at 1 year and 2 years from the beginning of the study with the ETDRS chart. On the ETDRS chart, the number of letters the patient can identify is recorded instead of the number of lines as in the Nellens chart. And as we shall see, the outcome parameters mentioned in most of these trials are the percentage of patients losing fewer than 15 letters, percentage of patients gaining 15 or more letters, and average number of letters gained or lost on the ETDRS chart. The other parameters which are usually mentioned are change in the retinal thickness at fovea and number of injections given, particularly in studies evaluating PRN and T&E regimens. So there are 6 pivotal trials comparing anti-VEGF therapy versus non-anti-VEGF therapy in neovascular AMD, and these are the VISION trial comparing pegaptanib versus sham, MARINA trial comparing Ranibizumab versus sham, ANCHOR trial comparing Ranibizumab versus PDT, PIER trial comparing Ranibizumab versus sham, trial by Sakyu et al. Comparing Bevacizumab versus combination of PDT with IVTA, and the ABC trial comparing Bevacizumab versus either PDT, pegaptanib or sham. So apart from the ABC trial, anti-VEGFs have been compared with non-anti-VEGFs, but in the ABC trial, patients receiving pegaptanib for neovascular AMD were also included in the control group. The VISION trial compared pegaptanib versus sham injections, both given every 6 weeks for 48 weeks in neovascular AMD, and a total of 1186 patients were included in the study. At 54 weeks, the study found that as compared to the sham group, the pegaptanib group had a significantly higher proportion of patients with visual acuity loss of 15 or fewer letters, but there was no significant improvement in visual acuity. And this was in contrast to the significant improvement in visual acuity which was demonstrated in subsequent studies on the other anti-VEGFs and for which pegaptanib has been withdrawn from the market. And at 2 years, the study found that patients continuing pegaptanib in the second year had significantly less risk of having visual acuity loss of 15 or more letters from baseline in the second year. The MARINA trial was a phase 3 trial comparing 2 doses of ranibizumab versus sham injections administered once a month over 24 months for occult and minimally classic MNV. We'll find that apart from MARINA and ANCHOR, most of the studies do not mention the type of MNV being treated in the trial. The MARINA trial included a total of 716 patients, and at 1 year the trial found that patients in the ranibizumab groups had a significantly lower visual acuity loss as well as a significantly higher visual acuity gain as compared to sham injections. And when considering the average number of letters gained in the respective groups, patients in the ranibizumab groups gained letters, while patients in the sham group lost letters. The MARINA trial also found that this benefit in visual acuity at 1 year was maintained at 24 months when ranibizumab injections are continued once a month in the second year. And during these 24 months, the MARINA trial reported that 1% and 1.3% of ranibizumab treated patients developed presumed endophthalmitis and serious uveitis respectively. The ANCHOR trial was another phase 3 trial which published its year 1 and year 2 results separately and compared 2 doses of ranibizumab administered once a month versus PDT administered at baseline and repeated if required based on findings on fluorescein angiography performed once every 3 months in patients with predominantly classic MNV over 24 months. So the ANCHOR trial differed from the MARINA trial in that the MARINA trial compared ranibizumab versus sham and the ANCHOR trial compared ranibizumab versus PDT. A total of 423 patients were included in the ANCHOR trial, and the ANCHOR trial found that at 1 year, patients in the ranibizumab groups had a significantly lower visual acuity loss as well as a significantly higher visual acuity gain as compared to patients in the PDT group. And when the average number of letters gained was considered, patients in the ranibizumab group gained letters, whereas patients in the PDT group actually lost letters. And the ANCHOR trial reported that presumed endophthalmitis occurred in 1.4% of patients receiving 0.5 mg ranibizumab. The ANCHOR trial also reported that the benefit in visual acuity at 1 year was maintained at 24 months and the incidence of endophthalmitis was 1.1% overall when all ranibizumab injected patients were considered, but the proportion of serious ocular and non-ocular events were similar in all the 3 groups. The PIER trial was a phase 3b trial which published its year 1 and year 2 results separately. A trial is said to be phase 3b when approval for the drug under trial has already been applied for but approval has not yet been received. In the first year of the study, the PIER trial compared 2 doses of ranibizumab versus sham injections as in the MARINA trial, but in the PIER trial, the injections were administered once a month for 3 months, followed by injections administered once every 3 months. And a total of 184 patients were included in the trial. At 1 year, the PIER trial also found that there was a significantly lower visual acuity loss and a significantly higher visual acuity gain in the ranibizumab groups as compared to the sham groups. But as compared to once a month ranibizumab dosing in the MARINA and the ANCHOR trials, once every 3 months ranibizumab dosing in the PIER trial resulted in a lower proportion of patients losing fewer than 15 letters and also a lower proportion of patients gaining 15 letters or more. And when we consider the average number of letters gained in the PIER trial as compared to the MARINA and ANCHOR trials. Patients in the PIER trial receiving once every 3 months dosing of Ranibizumab actually lost letters as compared to monthly dosing of MARINA and ANCHOR trials. So the treatment benefit declined during once every 3 months dosing following the 3 once a month loading phase, at the end of which the Ranibizumab patients had actually gained letters. And in the PIER trial, few ocular or systemic adverse effects occurred in any of the groups. In year 2 of the PIER trial, all patients were crossed over to monthly 0.5 mg Ranibizumab injections. First the sham patients after 14 months since the beginning of the trial, and then the Ranibizumab patients after 20 months since the beginning of the trial. And the trial found that in the study period after crossover from once in 3 month dosing to once a month dosing, except patients who received sham injections initially, all other patients showed increase in vision in this period. And as in the first year, the results in the second year of PIER trial were not as good as that observed with monthly dosing in the ANCHOR and MARINA trials. Sacco et al. Compared Bevacizumab administered initially as a loading dose of 3 once-a-month injections followed by once-a-month evaluations and repeat Bevacizumab injections as required versus PDT combined with intravitreal triamcinolone acetonide administered at baseline followed by once in 3 month evaluations and repeat PDT with triamcinolone acetonide as required over a period of 1 year. 28 patients were included in the study, and the study found that the mean change in visual acuity was a gain in number of letters in the Bevacizumab group, whereas it was a loss in number of letters in the combined PDT and IVTA group. And the Bevacizumab group showed a greater reduction in the mean central retinal thickness as compared to the combined PDT-IVTA group. The ABC study compared Bevacizumab versus standard treatment, with Bevacizumab being administered as a loading dose of 3 injections at 6 weekly intervals followed by evaluations at 6 weekly intervals and repeat Bevacizumab injections as required. And standard treatment included either PDT for predominantly classic MNV or pegaptanib or sham for minimally classic or occult MNV over a period of 54 weeks. 126 patients completed the study period, and the study reported a significantly lower visual acuity loss in the Bevacizumab group as compared to the standard treatment group, as well as a significantly higher visual acuity gain in the Bevacizumab group as compared to the standard treatment group. And when the average number of letters gained was considered, the patients in the Bevacizumab group experienced a gain in the number of letters, whereas patients in the standard treatment group experienced a loss in the number of letters. The ABC study did not report any cases of endophthalmitis or severe uveitis. Then we have the trials evaluating various Ranibizumab doses and regimens in neovascular AMD, and among them we have the EXCITE and the HARRIER trials, which were randomized controlled trials comparing various treatment doses and regimens of Ranibizumab, and the PrONTO and the SUSTAIN, which were non-comparison studies evaluating PRN regimen of Ranibizumab. The EXCITE was a phase 3b study comparing 3 treatment regimens: 0.3 mg Ranibizumab once a month, 0.3 mg Ranibizumab once in 3 months, and 0.5 mg Ranibizumab once in 3 months over 1 year. The quarterly regimens consisted of 3 once in a month injections in the loading dose phase followed by once in 3 month dosing. 293 patients completed the study protocol, and the study found that BCVA was maintained in all 3 groups, but BCVA gain was more in patients in the monthly regimen as compared to patients in the quarterly regimens, but non-inferiority limit specified at a 5-letter difference was not reached in the study. Non-inferiority studies involve statistical analysis which considers mean and confidence intervals of the groups being compared. And the study found that the gain in BCVA in the quarterly regimens was maximum in the first 3 months after the beginning of the study, that is at the end of the loading dose phase, but then decreased slightly from 3 to 6 months, following which BCVA was maintained from 6 to 12 months. Similar results were also achieved in intent to treat population, which included all patients initially randomized, and safety results were similar to previous pivotal Ranibizumab studies. The HARRIER trial is a randomized controlled trial considered as a phase 3 trial which compared 4 treatment regimens over 24 months. 0.5 mg Ranibizumab injections once a month, 2 mg Ranibizumab injections once a month, 3 once a month injections of 0.5 mg Ranibizumab followed by PRN dosing, and 3 once a month injections of 2 mg Ranibizumab followed by PRN dosing. PRN dosing implied once a month follow-up for evaluations and repeating Ranibizumab injections if there is 5 or more ETDRS later drop in visual acuity as compared to the previous visit, or there are signs of disease activity on OCT examination. A total of 1098 patients were included in the HARRIER trial. At 12 months, the HARRIER trial did not find any significant difference between the 4 groups as regards the percentage of patients maintaining visual acuity, percentage of patients having visual acuity gain, and average number of letters gained, and change in central retinal thickness. But the number of injections required was significantly less in the PRN group as compared to the monthly groups. At 12 months, the study concluded that excellent and clinically meaningful improvement in visual acuity and anatomic outcomes were achieved across all 4 treatment groups, and superiority of 2 mg Ranibizumab over 0.5 mg Ranibizumab was not demonstrated. The 0.5 mg PRN and 2 mg PRN regimens did not reach the non-inferiority criteria specified at a margin of 4 letters as compared to 0.5 mg once a month Ranibizumab regimen, and PRN regimens required approximately 4 injections less. Ocular and systemic adverse effects were consistent with data from previous studies and comparable across the 4 groups. And at 24 months also, the HARRIER trial did not find any significant difference between the 4 groups: percentage of patients maintaining visual acuity, percentage of patients having visual acuity gain, and the average number of letters gained, and change in central retinal thickness. But the number of injections required by the PRN regimens were significantly lower than the monthly regimens. So at 24 months, the HARRIER study concluded that clinically meaningful and similar BCVA improvement were achieved across all 4 groups, but there was a 40 to 50% reduction in number of injections required by patients in PRN regimen, and ocular and systemic adverse effects were consistent with data from previous studies and comparable between the 4 groups. The PrONTO study was a non-comparison study and so not an RCT, conducted over 24 months, and 37 patients completed the PrONTO study. The study evaluated PRN regimen of Ranibizumab, and participants in this study were initially given 3 once a month 0.5 mg Ranibizumab injections followed by once a month OCT evaluations and repeating injection only when 1 or more of the following are detected: the percentage of patients gaining visual acuity of 15 letters or more, and the mean gain in visual acuity in letters were comparable to MARINA and ANCHOR trials. And so the PrONTO study showed that results comparable to MARINA and ANCHOR trials can be obtained with fewer injections with a PRN Ranibizumab regimen. The SUSTAIN was also a non-comparison study and so not an RCT, which evaluated efficacy of Ranibizumab with an initial loading dose of 3 injections once a month and then PRN over 12 months, and it included 513 patients. They found that mean visual gain was maximum at 3 months at the end of the loading dose phase, decreased slightly from 3 to 6 months, and was then maintained from 6 to 12 months. So if we summarize till now, MARINA and ANCHOR evaluated Ranibizumab monthly dosing. PIER and EXCITE evaluated quarterly or once in 3 months Ranibizumab dosing. HARRIER, PrONTO and SUSTAIN evaluated PRN dosing of Ranibizumab, and ABC and the trial by Sakyu et al. Evaluated PRN Bevacizumab regimen. And apart from PrONTO and SUSTAIN, all the others were randomized control trials. Then we have an important group of trials comparing Bevacizumab and Ranibizumab in neovascular AMD. The importance of these trials lies in the fact that Bevacizumab is much less costly to the patient as compared to Ranibizumab, and among these trials, CATT and EVAN are the most important. The CATT trial was a National Eye Institute funded trial. The CATT trial compared 4 treatment regimens: Bevacizumab 1.25 mg once a month, Ranibizumab 0.5 mg once a month, Bevacizumab 1.25 mg as needed, and Ranibizumab 0.5 mg as needed, with a non-inferiority limit of comparison specified at 5 letters. It is important to note that the CATT trial did not have a PRN group but had as needed groups, because patients in the as needed groups received only 1 injection instead of 3 once a month loading dose as in a PRN regimen. The trial continued for 2 years, but at the end of 1 year, those who were receiving once a month injections of Bevacizumab and once a month injections of Ranibizumab at the initiation of the study were randomized to receive either once a month injections of the same drug or as needed injections of the same drug in the second year. But those who were receiving as needed injections in the first year continued to receive as needed injections of the same drug in the second year, and a total of 1185 patients were included in the CATT trial. And the data at the end of 1 year, at the end of 2 years from baseline, and in the second year were given in terms of maintenance of visual acuity gain of 15 or more letters and average number of letters gained, change in central retinal thickness, along with mean number of injections, and cost of therapy, where we find that cost of therapy with Bevacizumab was significantly less than cost of therapy with Ranibizumab. At the end of 1 year, non-inferiority comparisons of each group with each of the other 3 groups were done, and the CATT study at the end of 1 year concluded that Ranibizumab once a month injections yielded equivalent visual results as compared to Ranibizumab as needed injections. Bevacizumab once a month injections yielded equivalent visual results as compared to either Ranibizumab once a month injections or Ranibizumab as needed injections, and Bevacizumab as needed injections yielded equivalent visual results as Ranibizumab as needed injections, but Bevacizumab as needed injections were not non-inferior as compared to Bevacizumab once a month injections or Ranibizumab once a month injections. In the second year, because of the switching, there were 6 groups, and non-inferiority comparisons between the 4 groups continuing the same regimen showed that at the end of the second year, Bevacizumab once a month injections yielded equivalent visual acuity results as compared to Ranibizumab once a month injections. Bevacizumab as needed injections yielded equivalent visual acuity results as compared to Ranibizumab as needed injections, but once a month dosing was superior to as needed dosing with the same drug, either Bevacizumab or Ranibizumab, and macular atrophy occurred with greater frequency in patients receiving monthly regimen. And in the groups which were switched from monthly dosing in the first year to as needed dosing in the second year, there was a greater mean decrease in visual acuity in year 2 as compared to year 1, when they were matched with the patients in the same groups in the first year but continued to receive the same drug regimen. And also at the end of year 2, the switched groups had very similar visual outcomes as compared to patients receiving as needed regimen of the respective drugs since the beginning of the study. And as regards adverse events, at the end of 1 year, death occurred in 2% of patients overall without any significant difference between the groups. Arterial thromboembolic events occurred in 2 to 3% of patients in each group without any significant difference between the groups. Venous thromboembolic events, although occurring infrequently, was found more commonly in Bevacizumab once a month injection group, and when all serious systemic events were considered, whether related to anti-VEGF or not, incidence was higher in patients receiving Bevacizumab as compared to patients receiving Ranibizumab. And endophthalmitis occurred in 0.5% of patients without any significant difference between the groups. And similarly, at the end of 2 years, Death and arteriothromboembolic events were similar between the two drugs, and when all serious systemic events were considered, whether related to anti-VEGF or not, incidence was higher in patients receiving Bevacizumab as compared to patients receiving Ranibizumab. The IVAN trial compared 4 treatment regimens: Bevacizumab once a month injections, Ranibizumab once a month injections, Bevacizumab injections given in a discontinuous manner, and Ranibizumab injections given in a discontinuous manner over a period of 2 years with a non-inferiority limit specified at 3.5 letters. The discontinuous regimens received a loading dose of 3 injections given in monthly intervals, and following that, when retreatment was required by participants in the discontinuous groups, they were again given 3 once-a-month injections. 525 patients were included in the IVAN trial. The IVAN trial found that as regards BCVA, Bevacizumab was neither inferior nor non-inferior compared to Ranibizumab, and monthly regimens were neither inferior nor non-inferior compared to discontinuous regimens. But if instead of a non-inferiority limit of 3.5 letters, if the non-inferiority limit was specified at 5 letters, both comparisons would have been within the non-inferiority limit, showing that Bevacizumab was equivalent to Ranibizumab and monthly regimens was equivalent to discontinuous regimens. But still, Ranibizumab and monthly regimens tended to give better results. And so far as adverse effects were concerned, incidence of arterial thromboembolic events, heart failure, and serious systemic events were not found to be significantly different either between Bevacizumab as compared to Ranibizumab or between monthly regimens as compared to discontinuous regimens. But mortality was found to be higher in discontinuous regimens as compared to monthly regimens without any difference between Bevacizumab and Ranibizumab recipients. And the rate of macular atrophy was higher in monthly regimens as compared to discontinuous regimens. And a meta-analysis of pooled data of CATT and IVAN trials found that Bevacizumab is non-inferior to Ranibizumab and monthly regimens were non-inferior to discontinuous regimens. The mortality and risk of serious systemic adverse effects were higher with discontinuous regimens as compared to monthly regimens, but mortality, risk of serious systemic adverse effects, and thromboembolic events were similar between the two drugs, Ranibizumab and Bevacizumab. Macular atrophy was more frequent with monthly regimens as compared to discontinuous regimens, but did not differ between the two drugs. Other trials comparing Bevacizumab and Ranibizumab were GEFAL and MANTA, which compared Bevacizumab PRN dosing with Ranibizumab PRN dosing, and both found that there was no difference between the two regimens. And BRAMD study compared Bevacizumab monthly versus Ranibizumab monthly and found that change in BCVA and safety outcomes were similar in the two groups. The View 1 and View 2 were parallel phase 3 RCTs conducted simultaneously to compare Aflibercept and Ranibizumab in Neovascular AMD. And the View 1 and View 2 trials compared between the following regimens: Aflibercept 0.5 mg once a month injections, Aflibercept 2 mg once a month injections, Aflibercept 2 mg in a loading dose of 3 injections given once a month followed by 1 injection every 2 months, and Ranibizumab 0.5 mg once a month injections. The primary endpoint was percentage of patients maintaining vision at 52 weeks. In the second year, from week 52 to week 96, all participants received as needed injections but the same dose of the same drug, and the total of 2419 patients were included in these two trials. And each of the two trials found that the percentage of patients maintaining vision within 15 letters at 52 weeks were similar among the 4 groups. And when data from the two trials were combined, the mean change in BCVA in each of the Aflibercept groups were not significantly different from the Ranibizumab group. Also, the combined data from the two trials showed that mean change in central retinal thickness in each of the Aflibercept groups were not significantly different from the Ranibizumab group. At 52 weeks, the two trials concluded that all Aflibercept regimens were non-inferior and clinically equivalent to Ranibizumab once-a-month injections. All Aflibercept regimens were within 0.5 letters of mean change in BCVA as compared to Ranibizumab once-a-month injections, and all Aflibercept regimens produced similar anatomical outcomes on OCT. Also, ocular and systemic adverse effects were similar across all treatment groups. In the second year from week 52 to week 96, all subjects continued on the same dosage of the same anti-VEGF, followed up monthly, and received injections only on an as-needed basis, but at least once every 12 weeks. And the combined data from the two trials showed that at 96 weeks from baseline, percentage of patients maintaining vision were similar across all four groups, and the mean change in BCVA was also similar across all four groups. And as regards the mean change in central retinal thickness, the combined data showed that there was an average increase in fluid at 96 weeks as compared to that at 52 weeks in all four groups. And the proportion of eyes having no fluid at 96 weeks were less than that at 52 weeks across all treatment groups. And also, when data from both the trials were combined, the mean number of injections in the second year were lower in the groups receiving Aflibercept 2 mg once a month in the first year and Aflibercept 2 mg once every 2 months in the first year, as compared to patients receiving Ranibizumab 0.5 mg once a month in the first year. At 96 weeks, the two trials concluded that all Aflibercept and Ranibizumab groups were equally effective in preventing BCVA loss and improving BCVA, but more importantly, participants in the group receiving 2 mg Aflibercept every 2 months in the first year as compared to participants in the group receiving Ranibizumab once a month injections in the first year required fewer injections without any loss of efficacy. There were also small losses at 96 weeks from visual and anatomic gains achieved at 52 weeks across all groups, and ocular and systemic adverse events were similar across all treatment groups. The PULSAR was a phase 3 RCT evaluating a higher dose of Aflibercept and compared three groups, one receiving Aflibercept 8 mg every 12 weeks, the second receiving 8 mg Aflibercept every 16 weeks, and the third receiving 2 mg Aflibercept every 8 weeks over a total period of 96 weeks. And each of the groups received a loading dose of 3 initial once-a-month injections. Also, the groups receiving 8 mg Aflibercept every 12 weeks and 8 mg Aflibercept every 16 weeks had their dosing intervals adjusted if required. A total of 1009 patients were included in this trial. At 48 weeks, the trial found that both the 8 mg Aflibercept every 12 weeks and 8 mg Aflibercept every 16 weeks were non-inferior to Aflibercept 2 mg every 8 weeks. Also, the ocular adverse effects profile were similar among the three groups. And at 96 weeks, although the data is not published yet, 78% of patients could be maintained on a dosing interval of 12 weeks or more throughout 96 weeks of the study. The HAWK and HARRIER trials were parallel phase 3 RCTs conducted simultaneously to compare Brolucizumab versus Aflibercept in Neovascular AMD, and these trials compared three groups, one receiving Brolucizumab 3 mg, second receiving Brolucizumab 6 mg, and the third receiving Aflibercept 2 mg. Only in the HAWK trial there was a group receiving Brolucizumab 3 mg, but not in the HARRIER trial. And each of these groups, after receiving a loading dose of 3 once-a-month injections, the Aflibercept group received injections once every 8 weeks, and the two Brolucizumab groups were injected once every 12 weeks. But if disease activity was detected in any examination at any predetermined intervals, the treatment intervals were shortened to 8 weeks and remained so till the end of the trial. A total of 1817 patients were included in the HAWK and HARRIER trials, and the primary hypothesis was non-inferiority in mean change in BCVA at 48 weeks, with the non-inferiority limit specified at 4 letters. And at 48 weeks, both the trials found that each Brolucizumab group was non-inferior to Aflibercept in mean BCVA change from baseline. And the percentage of eyes achieving gain in BCVA were also similar among the three groups, and greater than 50% of patients receiving Brolucizumab 6 mg could be maintained on a treatment interval of once in 12 weeks up to week 48. Also, anatomic outcomes favored Brolucizumab over Aflibercept, and this is very important to remember. And patients receiving Brolucizumab had greater reductions in central retinal thickness as compared to patients receiving Aflibercept. And at week 16, fewer recipients of Brolucizumab 6 mg had disease activity as compared to recipients of Aflibercept 2 mg. And adverse event rates were similar with the two drugs, Brolucizumab and Aflibercept. At 96 weeks, the HAWK and HARRIER trials found that the mean BCVA change from baseline was similar in all the three groups, and the percentage of patients who could be maintained on Brolucizumab 6 mg at treatment intervals of 12 weeks till week 96 was 45.4% in HAWK and 38.6% in HARRIER trial, and this was slightly less than that found at week 48, and among patients who could be maintained on Brolucizumab 6 mg administered at 12-week intervals till week 48, there was an 82% and 75% chance of remaining stable with Brolucizumab 6 mg administered at 12-week intervals till 96 weeks in HAWK and HARRIER trials respectively. And as at week 48, at week 96, both HAWK and HARRIER trials found that there was greater reductions in retinal thickness with Brolucizumab 6 mg as compared to that with Aflibercept 2 mg. And at week 96, fewer patients receiving Brolucizumab 6 mg had subretinal or intraretinal fluid as compared to patients receiving Aflibercept 2 mg. At 96 weeks, the HAWK and HARRIER trials concluded that Brolucizumab demonstrated greater fluid resolution as compared to Aflibercept, and the once in 12 weeks dosing potential of Brolucizumab observed at week 48 could be maintained to week 96. Brolucizumab showed an overall well-tolerated safety profile, but 4.4% of patients receiving Brolucizumab 6 mg developed intraocular inflammation or IOI as compared to 0.48% patients receiving Aflibercept 2 mg. And this intraocular inflammation had the potential to induce retinal arterial occlusion, and this is important to remember. So the study recommended that Brolucizumab should not be re-administered in these eyes which experienced a previous episode of Brolucizumab-induced IOI, but these eyes can be given another anti-VEGF but only after resolution of the previous episode of IOI. The TENAYA and LUCERNE trials were parallel phase 3 RCTs comparing Faricimab and Aflibercept in Neovascular AMD, and the comparison was between two groups, one receiving Faricimab 6 mg in a treat and extend regimen with a loading dose of 4 injections once every 4 weeks, followed by evaluations at week 20 and 24 with repeat injections as required but without exceeding the treatment intervals beyond 16 weeks. And after week 60, a personalized treatment interval was followed, in which Faricimab was administered once every 8 weeks to 16 weeks based on individualized treatment response, and the other group received Aflibercept 2 mg with a loading dose of 3 injections once every 4 weeks, followed by repeat injections once every 8 weeks. A total of 1113 patients were included in the TENAYA and LUCERNE trials. And the TENAYA and LUCERNE trials found similar gains in visual acuity between the two groups, and the percentage of patients who could be maintained on Faricimab at treatment intervals of 16 weeks till the end of the study was 60% or more, and the percentage of patients who could be maintained on Faricimab at treatment intervals of 12 weeks or longer till the end of the study was 75% or more. Among the trials evaluating treat and extend regimens, we have the LUCAS, TREX, TREND, RIVAL and ARCHWAY trials. The LUCAS trial compared Bevacizumab treat and extend regimen versus Ranibizumab treat and extend regimen on 421 patients over 24 months, and the study found similar changes in visual acuity and central retinal thickness in the two groups, but Bevacizumab group required significantly more injections, and arteriothrombotic events, specifically non-fatal MI, was higher in Ranibizumab group. The TREX-AMD trial compared ranibizumab monthly versus ranibizumab treat and extend over 24 months. 50 patients were included in the trial, and the visual outcomes were not significantly different between the two regimens. The anatomic outcomes were also not significantly different between the two groups, and the treat and extend cohort required significantly less number of injections as compared to the cohort receiving monthly injections. At 24 months in the TREX trial, mean maximal tolerated interval of injections in treat and extend cohort was 8.5 weeks, and 47% of patients in T&E cohort could be maintained with injections at intervals of 8 weeks or more. The TREND trial also compared ranibizumab monthly regimen with ranibizumab treat and extend regimen, but over 1 year. 650 patients were enrolled and 90% completed the study. And the study also found that treat and extend regimen was non-inferior to the monthly regimen of ranibizumab. And the TREND trial showed that mean number of injections as well as the mean number of visits in the treat and extend cohort were lower than the mean number of injections and the mean number of visits in the monthly cohort. The rival study compared Aflibercept T&E regimen with ranibizumab T&E regimen over 24 months. The primary endpoint of the rival study was change in GA area from baseline, which showed no statistically significant difference between the two groups. The mean change in BCVA from baseline also showed no statistically significant difference, and the mean number of injections required per year in the two groups was similar. The ARCHWAY trial was a phase 3 randomized control trial comparing ranibizumab refillable port delivery system or PDS, also known as Susvimo, as seen here in these two photographs, which were refilled every 24 weeks versus ranibizumab given once in a month over 24 months. This study included patients who were diagnosed with neovascular AMD within the previous 9 months, receiving and responsive to previous anti-VEGF therapy. So this study is an exception in that it did not include treatment-naive patients. A total of 418 patients were included, and the ARCHWAY trial found that the PDS cohort results were non-inferior to ranibizumab monthly injections, both in terms of visual acuity as well as anatomic outcomes. Here we see a very slight visual acuity change in the negative direction because the patients were already receiving anti-VEGF and were responsive to it. And approximately 95% of patients in PDS cohort did not require supplemental ranibizumab injections in the refill interval. Complications in the PDS group included cataract, which occurred in both the groups, conjunctival erosion, conjunctival retraction, endophthalmitis, and implant dislocation. Visual outcomes in clinical practice as compared to visual outcomes in randomized controlled trials are inferior, and this may be due to several reasons. RCTs usually include patients with a minimum visual acuity, and the method of visual acuity assessment often differs between RCTs and clinical practices. Duration of follow-up in RCTs is usually not beyond 2 years, but in clinical practices, patients are often followed up for much longer times. Patient compliance to follow-up is much more rigorously maintained in RCTs, and access to medications may be suboptimal in clinical practices due to economic factors. And real-world outcomes of anti-VEGF therapy in neovascular AMD has been evaluated by several studies which are mostly retrospective in nature. Among them we have the AURA study, which was a retrospective study on more than 2000 patients who received at least one ranibizumab injection and were evaluated over 2 years. And the mean improvements in BCVA were only plus 2.4 letters at 1 year and plus 0.6 letters at 2 years as compared to plus 5 letters to plus 8 letters in RCTs. The 7-UP study evaluated 65 patients who were originally included in the MARINA and ANCHOR trials and who completed a mean of 7.3 years of follow-up. Horizon study was an intermediate study of 2 years duration following the conclusion of the MARINA and ANCHOR trials, and in both the Horizon study and the patients evaluated in 7-UP studies were given ranibizumab as required without any rigorous follow-up protocol. And the 7-UP study showed that almost 40% of patients had BCVA of 20/200 or worse at 7.3 years of mean follow-up, as compared to more than 90% of patients in the MARINA and ANCHOR trials maintaining vision at the end of 2 years. Overall mean change in letter score from baseline, that is at entry into the ANCHOR and MARINA trials, was minus 8.6 letters at 7.3 years, as compared to a gain in BCVA at the end of 2 years in the ANCHOR and MARINA trials. And the 7-UP study also found that patients receiving more injections in the interval since exit from the Horizon study had significantly better mean change in BCVA, and macular atrophy was detected by fundus autofluorescence in 98% of patients of ANCHOR and MARINA trials who were followed up for 7.3 years. But macular atrophy was not a significant consideration in the initial 2 years of these two trials. 647 patients among the original CATT trial patients were followed up for 5 years, and here also, following the formal 2 years of CATT trial, patients visited when required, and when treatment was required, the drug and regimen were selected by the ophthalmologist and not according to any pre-specified protocol. The 5-year extension of CATT trial also found that vision gains were not maintained at 5 years, with 20% of eyes having a visual acuity of 20 by 200 or worse, and the mean change in BCVA was minus 3.3 letters from baseline, that is at entry into the CATT trial, and minus 10.8 letters from the end of 2 years of the formal CATT trial. The difference between the two drugs, Ranibizumab and Bevacizumab, at the end of 5 years was also not significant. The Pan-American Collaborative Retina Study Group was a prospective trial of intravitreal Bevacizumab given in a PRN regimen whenever CNV became active over 5 years and included 292 eyes. This study also found that more than 35% of patients lost 2 or more lines of vision at the end of 5 years. A retrospective study was done on almost 14,000 patients with Neovascular AMD who received Ranibizumab, Bevacizumab or Aflibercept for 1 year based on the IRIS or Intelligent Research Insight Registry database. And this study also found that those who received more injections had a better final visual outcome, but no difference in efficacy between the 3 drugs were observed. The study by Seula et al. Was a retrospective study on almost 50,000 eyes receiving any anti-VEGF for neovascular AMD, and 1-year results were analyzed in this study. The average number of injections patients evaluated in this study received was 7.3, and the mean change in BCVA was plus 1 letter. And this study also found that those who received more injections had a better final visual outcome, with those receiving 4 or fewer injections having a decrease in visual acuity, those receiving between 5 to 9 injections showing a linear relation between improvement in visual acuity and number of injections, and those receiving 10 or more injections reaching a plateau. And also, older patients and those with poorer visual acuity at baseline tended to receive less injections, but there was no difference in efficacy between the drugs. And study by the United Kingdom Aflibercept users group was a retrospective study on almost 2,000 eyes who were given Aflibercept according to VIEW protocol. And this study found that even if regimen can be maintained, real-world data was inferior to randomized control trials. So although the number of injections was similar between patients in this retrospective study and in the VIEW trials, the mean change in BCVA in this retrospective study was much less than that in the VIEW trials. Then there were trials evaluating combination therapy. The MONT, BLANC, DENALI and VIA studies compared anti-VEGF monotherapy versus combination therapy of anti-VEGF and PDT. The study showed no additional benefit of combination therapy as compared to anti-VEGF monotherapy. And trials comparing anti-VEGF monotherapy versus combination of anti-VEGF with platelet-derived growth factor inhibitors showed no additional benefit of combining PDGF inhibitors with anti-VEGF. Then we have the drugs which have not been approved yet by FDA and are either available elsewhere or are still in development, and among them we have the anti-VEGFs Conbercept, which has been developed in China and approved for use there, Abicipar Pegol, which has been approved in Europe but has not been approved by FDA because of a significant risk of intraocular inflammation, KSI 301, and Sozinibercept, which binds and inhibits VEGF C and D, and it has been found that Ranibizumab combined with Aflibercept showed better results as compared to Ranibizumab alone. Other than anti-VEGF molecules which are being evaluated for neovascular AMD therapy include tyrosine kinase inhibitors, tissue factor inhibitors, placental-derived growth factor inhibitors, pigment epithelium-derived growth factor, tissue inhibitors of matrix metalloproteinase, and gene therapy to induce expression of proteins in retinal cells such as soluble VEGF-R1 receptor, proteins resembling Ranibizumab and Aflibercept, and angiotensin and endostatin. Biosimilars are molecules which are structurally similar but not identical to the original anti-VEGF molecule, with no clinically meaningful difference in purity, safety, and potency. Biosimilars are different from generics, as generics are structurally identical to the brand name product, and generics are usually of small molecules, whereas biosimilars are usually of larger molecules such as immunoglobulins. And FDA regulation for biosimilar holds that once the biosimilar attains non-inferiority to the reference product, the biosimilar gains all approved indications of the reference product. To recap the salient points, MARINA and ANCHOR trial showed superior efficacy of Ranibizumab once-a-month injections as compared to sham and PDT. The ABC trial showed superior efficacy of Bevacizumab over sham. EXCITE trial showed that when quarterly once in 3 months injections were administered following a loading dose, the gain in vision is maximum at 3 months, decreases slightly from 3 to 6 months, and then remains stable from 6 to 12 months. The PIER trial also showed that decline of visual acuity occurs during quarterly once in 3 months injections. The HARRIER trial and PrONTO study showed equivalent efficacy of Ranibizumab PRN as compared to Ranibizumab once-a-month injections, with a significant reduction in the number of injections in the PRN group. The SUSTAIN study showed that with PRN regimen of Ranibizumab, the gain in vision is maximum at 3 months, decreased slightly from 3 to 6 months, and then remained stable from 6 to 12 months. The CATT and IVEN trials compared Bevacizumab and Ranibizumab, each given either as monthly injections or as needed injections. First-year results of CATT trial showed that Bevacizumab once-a-month injections is equivalent to Ranibizumab once-a-month injections and Ranibizumab as needed injections, and Bevacizumab as needed injections is equivalent to Ranibizumab as needed injections, but Bevacizumab as needed injections is not non-inferior to either Bevacizumab once-a-month injections or Ranibizumab once-a-month injections. In the second year, the CATT trial showed that Bevacizumab once-a-month injections is equivalent to Ranibizumab once-a-month injections, and Bevacizumab as needed injections is equivalent to Ranibizumab as needed injections, but as needed regimen is inferior to monthly regimen for each of the two drugs. But more importantly, there was a significant reduction of cost of therapy to the patient in the Bevacizumab group as compared to the Ranibizumab group. The CATT trial also showed that incidence of death and arteriothromboembolic events were similar in all the groups, but when all serious systemic events were considered, whether previously related to anti-VEGF or not, incidence was higher in Bevacizumab recipients as compared to Ranibizumab recipients. The VIEW 1 and VIEW 2 trial showed that Aflibercept is non-inferior to Ranibizumab, but patients on Aflibercept can be maintained with fewer number of injections. The HAWK and HARRIER trial showed that Brolucizumab is non-inferior to Aflibercept as regards visual outcome, but Brolucizumab has a superior fluid resolution efficacy as compared to Aflibercept. Also, almost half of the patients on Brolucizumab can be maintained with once every 12-week dosing of Brolucizumab. Brolucizumab patients, however, had a higher incidence of severe intraocular inflammation as compared to patients in the Aflibercept group. TENAYA and LUCERNE trial showed that Faricimab is non-inferior to Aflibercept as regards visual outcome, but more than 60% of patients receiving Faricimab can be maintained on once in 16-week dosing. The TREX-AMD and TREND trial showed that Ranibizumab treat and extend is equivalent to Ranibizumab once-a-month injections, but both the number of clinic visits and number of injections can be reduced with treat and extend regimen. Studies evaluating real-world outcomes such as AURA, 7UP and 5-year results of the CATT trials showed poorer visual outcomes as compared to RCTs. Trials evaluating combination therapy of anti-VEGF with PDT and other agents have not shown additional benefit till date. Biosimilars are structurally similar but not structurally identical to the original drug molecule with similar efficacy and safety profile as compared to the original drug molecule. Thank you for listening.